Let's move on to penetrating trauma. Penetrating trauma, we talked a little bit about it as far as ballistics, and I did talk a little bit with penetrating trauma. And that penetrating trauma was our ballistic profile as far as our firearms, our handgun and rifle. But we also can think about penetrating trauma as being anything else, a low velocity, like a stab wound or somebody being punctured or impaled on some type of sharp object. When these ballistic type profiles, we look at a lot of tissue damage as the projectile or penetrating trauma travels through, and we would look at that mechanism and understand that mechanism and somehow come to a conclusion of the potential injuries. Now, as far as ballistics goes, remember I told you about the projectile, that round that's coming out of that muzzle. As it comes out of that barrel, the energy load behind it pushes that projectile downrange towards the target, and as it goes down towards the target, it usually travels a straight trajectory. That trajectory, once it penetrates and hits that object, it can then disseminate upon impact. It can then tumble or yaw and float through, or it can go straight through. And if it does go straight through, a lot of these times when that projectile is entered and exiting through our patients, it causes this temporary cavity, or what we call cavitation. This is your secondary energy. As that blast, that projectile goes through, it causes these blast waves to push tissue around it. When we look at lower level energies, as far as penetrating trauma, we're looking at the length, potentially the diameter or cutting edge, and we're looking at the force as far as how much thrust was used to damage through the skin and enter into cavities as far as chest, abdominal, or extremity areas. If we know the length and cutting edge, the force, this may give us an idea of how much or what limiting damage it had done. For example, a 16-inch sword versus a 2-inch paring knife is much different injury profile than we can see. But when we look at these low energy source penetrating trauma, these are the type of hand weapons, or a knife, a sword, or even some type of impalement. There is what we call a Kona injury. So we look at the diameter of that Kona injury being the length of that projectile or that penetrating trauma. And so a type of cones, and that's where we look at just not the injury going in, but it could be twisting, turning, or rotational forces as that penetrating trauma went in, causing more severe damage. So again, the Kona injury, we may not have a straight pattern. There may be some twisting or thrusting, and depending on the location, the higher the energy, we can multiply that damage and injury 2 to 4 times more. And think about those areas again. If we're looking at the chest cavity, we're looking at organs within the chest cavity, the lungs, the great vessels, the digestive system, as well as the myocardium and pulmonary organs. When we're looking at the intra-abdominal organs and retroperitoneal ones, if it's from the posterior wall, we may be looking at the solid organ as far as the kidney. But as we look at the intra-abdominal organs, we have our hollow and solid organs, or solid organs being the liver and spleen. And then we're looking at the large blood vessel. Our hollow organs anywhere from the stomach all the way down to the intestines. Why do we mitigate these types of injuries? Well, usually if you are put in the line of fire, then you'd be wearing some type of body armor. Not everyone is given body armor or wears body armor for a living, but these would tend to protect them from ballistics. It all depends on what the rating of that body armor is. Now, wound profiles are high and medium energy. This discharge from a high velocity projectile, as it travels down range, the larger the round is, the more drag it has. This decreases the velocity or penetrating trauma. Now look to where it penetrates, parts with cavity, and we can then anticipate a wound track. Remember, distortions can occur because of this cavitation, which is this projected gas. However, the projectile can tumble and yaw. It also can fragment upon hitting our patients. Shotguns, they are slightly different than your regular projectiles. This has a more dispersed type pattern. It has a lot of expensive gases that come out of the barrel, and this causes more of like a blast type of injury. So shotguns cause a dispersal pattern. They have a lot of pellets in them. The charge comes out, and it depends on what size that charge or what size the pellets that are using and the wadding. But this type of pattern usually peppers out. The closer the person is, the deeper and worse that type of injury is. The further away, the farther the fragmentation and peppering. They give us some scales as far as the type of injury. The closer the worse, the further away, more of this less concentrated pattern and peppering of injuries. Muzzle contact from this can cause a significant type of burn pattern and round and oval at the actual injury or entrance site. And usually the exit site is much bigger. However, it's not our job to determine whether or not it's entry or exit. All we need to do is, if we know that we have one entrant, please look for a secondary exit point, and just be concerned as the bullet does travel sometimes in a non-straight pattern or an alternative pattern. For example, in head injuries, projectile projection can be changed as it enters into the cranial vault, and sometimes there's some limited penetrating power, but there's a lot of mass destruction based on fragmentation of the cranial vault as it disperses and enters into the cerebrum. Thoracic injuries, we look at pulmonary damage, vascular damage, and cardiac damage. This can lead to hemo and pneumothorax. This can lead to pericardial tamponades and a lot of hemorrhaging going on. Let's just take a look. So in the head, let's step back now. So in the head, if they're bleeding, we don't want to control that bleeding. We want that bleeding to slowly ooze out for fear of causing increase into cranial pressure. Again, we looking for Cushing's triad and then Beck's triad. When we look at myocardium, but when we look at the myocardium as far as cardiac and pericardial tamponade, we look at Beck's triad, and then as we go into the abdominal injuries, we look at solid and hollow organs being damaged. Not to mention that it can go straight through and hit the vertebral column. Extremities, we look at vessel, nerve, and musculoskeletal type injuries. Bones get fragmented. Projectiles cause the fragmentation. It changes, decreases, or increases the injury pattern. And then we have external rotations or shortening of the extremity. And we gotta make sure we take care to assess for arterial involvement. Now, the periosteum and the bone will continue to bleed or ooze, so we need to control hemorrhage that way. We won't be able to put a tourniquet to compress the bone from bleeding, so you need to control it on that end. Now, let's just go over real quick. So the brain cannot cause hypovolemia on itself. It is an enclosed surface. We have only three components: brain, cerebrospinal fluid, and blood. And there's no way that's going to cause the severe hypotension. Now, if we move further, so the idea is to look for hypotension elsewhere. When we look into the thorax or the chest cavity, we can see the lungs at least capturing one side of the lung, close to about 1,500 cc's total, about 3,000 in both upper thoracic cages. Not to mention that it does cause compression on the myocardium and the great vessels. This may automatically cause a hypotension. So we might want to take a look and think about tension pneumothorax and pericardial tamponade as a result of hypotension, not just only blood loss or hemorrhage as a result of the penetrating trauma. When we look in the abdomen, the abdominal contents can hold quite a lot of blood in there, and we know that we have a lot of solid organs that can tend to bleed out. And this will probably bleed out in just a few minutes, as we know. Our heart rate circulates 70 times per minute. We look at about 6-7 liters being pushed around in that first minute, and we're probably in the first few minutes, most of the blood will be exsanguinated throughout the intra-abdominal wound. Look for the belly becoming large and distended. And hopefully we can put some kind of compressive force to stop the bleeding. Now, lower extremities, our femurs can hold close to about 3,000 cc's of fluid. Your rib holding maybe about 100. Your forearms about 200. Your humerus maybe about 500, and so on. So control hemorrhage and think about the injury patterns. Think about these incidences and how we're going to manage them. That's our next couple presentations.